Ahmed, vous êtes soignant à la base, il faut vraiment le rappeler, chirurgien. En plus, vous évoluez dans un univers qui est difficile, qui est l'oncologie, qui demande énormément d'humanité. Lorsque l'on parle à des patients, quelle est votre réaction lorsque vous voyez ces mondes virtuels et la possibilité demain d'avoir des avatars en face de vous?
So, hi everyone. Good afternoon. So I think it's not one or the other. That's the first thing. It's not exceptionalism. It's adding value to different ways of working. That's all it is. If you look at the continuum where we're in, where face-to-face is still the model of care that we all aspire to, nothing will change the face-to-face environment, particularly when you have patients require empathizing or breaking bad news or holding hands. It's still very much part of the human nature. But a lot of the healthcare system that we have could be developed or changed into virtual environments or in the metaverse, for example. And so what we're seeing during the pandemic over the last few years is a change from people's perception about virtual care. 3 years ago, we didn't have virtual care. It was an anomaly. It was only exacerbated and supported and accelerated by the pandemic. Suddenly, 3 years later, we're now breaking bad news for cancer treatment on a telephone or on a telemedicine platform, which would have been unbelievable 3 years ago. Society is changing, it's adapting. And I think the patients themselves are very prone to adapting. We forget the end user, the patients. What do they need? What do they want? Now we're seeing they want care that's immediate, at home, at their convenience, avoiding the costs going to hospital, for example. It's community-based care and social care. The things have changed. Therefore, healthcare is also now relying on virtualization. So what do people expect? This is going to be a kind of conversation as we go on. What parts of healthcare can we practice virtually? What parts will we need to face-to-face? I think it's a smart move to think about different ways of working. If you look at the background, the cost of healthcare going up year on year. The GDP, for example, in the UK is at 9-10%. In the US, it's 7-20%. So we can't sustain that level of cost going forward. And that's expensive because of bricks and mortar, hospitals, buildings, and people. So can we have a smarter healthcare system that has more virtual care, that's more convenient for our patients, but also is cost effective? And so it's about the experience that patient has. The other thing when you talk about the patients themselves is that experience. We talk about UI and UX in computer science, right? The user interface, the user experience. We never talk about that in healthcare. We don't worry about the experiences. So I think all of those kind of ideas lend themselves well to having therapy and healthcare in that metaverse. Even in cancer care, so for example, I'm a cancer surgeon, I have been for 30 years. I think what elements of that could be done? So for example, follow-up. If you have a cancer operation, I perform an operation, I'm a colorectal cancer specialist, and then we have a 5-year follow-up for cancer. Does that 5-year follow-up need to be done face-to-face? When all they do, the patients travel, maybe an hour, come to the clinic, wait 2 hours to be seen, pay a lot of money for car park charges, get anxious waiting, then they come in for a 5-minute appointment and say it's all fine, your scans are normal, and they go home. Is that relevant? Is that efficient use of time? Of course it isn't. Could that be done in a different way, with virtual avatars, holograms, appearing in your own room? So look, your scans are fine, we're happy. Yes? So it's how much of that care can we push into a different way of working? And that's about the social re-engineering of society, is engaging with our patients and our public, also helping the medical profession develop those ideas as a kind of a hybrid model of working in the future.
Au fur et à mesure que je vous écoute, docteur Ahmed, je me demande si vous n'êtes pas en train, quelque part, d'inverser la relation médecin-patient. On a quand même été, et on est toujours, dans une relation qui est très descendante, très top-down, entre le médecin sachant et le patient, patientant d'ailleurs, par les temps qui courent, plutôt que patient, avec un médecin qui sait, et avec un médecin qui va aussi décider de la forme que la relation va prendre. Beaucoup de médecins vont encore vous dire la téléconsultation est un pis-aller. La véritable consultation avec un grand C, c'est la consultation de cabinet avec la palpation, sans se poser, comme vous le dites tout à l'heure, la question de ce que veut réellement le patient et ce dont a réellement besoin le patient. Est-ce que vous n'êtes pas en train de casser quand même une logique multiséculaire chez les médecins?
we have to keep developing. We can't carry on. Healthcare is broken. Okay, it doesn't work at the moment. As you know, we're spending endless amount of money, endless amount of effort trying to create a healthcare system that is just broken at the very sight of it. So you have to develop and change a smarter workforce, smarter way of working, and these ideas lend itself well. And patients themselves also, remember, are demanding change. They're not wanting to come to hospitals. They want to be well at home. They want convenience at their home. They want wearables, connectivity, et cetera, So I think that is a changing paradigm. If somebody sits there and says, all I want to do as a doctor, to do face-to-face, I'm afraid they're going to be obsolete fairly soon because the system will just develop much faster than they are able to perform. We have to be productive. We have to be flexible. We have to change the way our models of care to allow different ways of working, allowing patients to be, be seen in different ways. So I think that is kind of where we are in the social construct of society. But I think also as doctors, we need to, embrace those new ideas almost as part of the leadership. You're right about the hierarchy. We've always been hierarchical in medicine. The doctor knows best, for example. That's changing. Does the doctor know always best, or now is it a collaboration? Is it a partnership with our patients? I think it's changing, and the terminology is more about collaboration and key partnerships with our patients.
Docteur Ahmed, une autre question. On disait que certains patients pourraient peut-être se sentir plus libres, exprimer plus facilement leurs questions, leurs besoins, leurs doutes, en étant sous forme d'avatar dans une cité virtuelle. Mais est-ce qu'il n'y a pas quand même pour vous, en tant que soignant, des éléments qui vont vous manquer? J'essaie de comprendre comment la relation patient-médecin est en train de se transformer dans le métaverse. Une relation, c'est aussi une rencontre. Face à vous, il y a certainement des patients qui expriment verbalement des choses et qui, par leur corps, sont en train d'exprimer le contraire ou toute autre chose. Et le regard du médecin, c'est quand même à un moment d'arriver à faire la différence entre les deux. Comment faire lorsque l'on a un avatar en face de soi?
Okay. That's a very good question, by the way. I think there's a few elements that we need to unpick. The value of the human interaction obviously can't be underestimated. The value of the body language, the sense of having a face, to seeing the emotions, for example, et cetera, absolutely very valuable. And that lends itself well to those key human interactions of intuition and judgment. Okay, and I think that's a problem we have going forward. Could avatars, holograms, or digital humans, for example, obtain intuition or judgment, which I think is difficult. I don't think we're ready for that yet. That's a difficult conversation. Maybe in 10, 20, 30 years' time, as we approach the singularity, maybe we'll have computers that are powerful enough or systems that are powerful enough. So, but again, it's about flexibility. It's not one or the other. Okay, we're not saying you either do this or you do that. No. It's a combination. It's a journey. It's a process. And we're discovering now, say for Michael's company, Imedis, working out what does that healthcare look like in the metaverse? What diseases or illnesses will lend itself well? Treatment. Do we just create a new hospital in the metaverse? Is that what's required? Or do you create experiences that might be more valuable? For example, for well-being, for mental health, for psychology, whatever, things that might add value in an immersive environment. Therefore, we have to explore what that new world could offer and what it could look like. And perhaps throw away the maps of the old hospital, of the old ways of working, and rethink that model. So I think it allows us to almost reimagine what could be possible in that sense, right? And that's what I think we should do. But again, that's a journey, time will take, and Michael will discover with his company Imedis, who I'm working with, to understand, okay, which areas can we contribute first? Then, to validate it. As researchers, scientists, we have to validate our work and ensure that what we're offering is quality.
Cela veut dire, dans votre raisonnement, qu'un hôpital virtuel, par exemple, pourrait, pourquoi pas, avoir, on imagine, des urgences virtuelles et effectuer un premier tri des malades, là où ils n'ont pas forcément accès à un hôpital physique, pour savoir qui doit réellement être orienté vers un médecin physique, vers une consultation physique?
I think it's going to be a mixture of those. Some will just have therapy. So the metaverse, remember, is not just about a place where you might see a person. And this is what I'll talk about in my keynote at 5 o'clock. It's creating the economy in the metaverse, right? It's the whole concept. It's payment models. It's how you share data, how you protect data, how you see people with avatars and holograms. It's having NFTs as a back end. It's creating a semantic web. It's not just about that one interaction. It's creating society almost within a society that's purely digital. So I think that's what people fail to understand when we're creating what's called the metaverse or the metaverse. It's much more than just having an interaction with a patient.
Dans les règles que pourrait totalement casser, par exemple, notre métaverse, une des règles, c'est la règle territoriale. Je ne sais pas comment les choses se passent au Royaume-Uni. En France, on est encore dans des règles territoriales très fortes, avec pourtant une proposition médicale très différente selon les territoires. On voit qu'en santé mentale, on en parlait dans cette même salle l'année dernière, la proposition de soins ou de soignants que vous avez en région parisienne n'a rien à voir avec la proposition de soins ou de soignants que vous avez dans la Creuse, pour citer un département par hasard. Or, on est encore dans un système où même pour être remboursé, il vous faut aller voir un médecin ou un professionnel près de chez vous. Est-ce qu'avec le métaverse et ces cités virtuelles, on n'est pas en train de renverser totalement la table ou l'échelle territoriale physique?
So it's actually more local than before. You remember you're separating different geographies, say in France, different centres, where you have to go and see certain physicians at certain places. That might be limiting for some people. Perhaps what this will allow you to do is democratise healthcare much better. Should you not be, as a patient, allowed to see anybody around France, or perhaps even around the world? If you pop into the metaverse, see the right person seamlessly and fairly simply, rather than go through the barriers of referral through geography, etc. So I think you're creating a seamless society, a decentralized platform that actually democratizes healthcare. That's the vision we have. And perhaps we've got to think much bigger than be constrained by geography and boundaries and have care that is really simply universal.
Docteur Ahmed, j'ai envie de vous poser la même question. Quel est l'intérêt pour vous, qui avez fait en plus des espaces de formation virtuels, qui les commercialisez dans votre société, quel est l'intérêt d'avoir des formations supplémentaires dans le métaverse? Est-ce que ça veut dire que les facultés de médecine doivent s'ouvrir? Est-ce que la connaissance doit s'ouvrir à un public qui ne soit pas forcément non plus uniquement un public soignant?
If you take the last couple of years, where before education was delivered largely face-to-face, some of it was online on e-platforms, and we moved to kind of your Zoom and Teams platforms for learning, that gave itself an opportunity for virtual learning. So virtual reality, augmented reality is not that new. It's been around for a few years, but we lack the market for it. The last 2 years, suddenly, the world is crying out for new ways of learning as a kind of a continuum from the online platforms to this virtual world. So, for example, now we're seeing major organizations, medical schools, universities, hospitals, embrace XR training. We call it XR, for example. So we've seen the advantages, for example, in surgical training, for simulation training, where it has huge value and additional value for the students. We've brought in some of the XR training at our medical school. So, for example, last year during the pandemic, I gave an example over lunch, that our students suddenly for a year could not go to the wards because of the pandemic. They were repurposed to the kind of the intensive care or nursing support. They didn't have any clinical experience. So suddenly we're in a hiatus with no alternative. I then used the XR technology to do live ward rounds in VR and XR on the wards, had the students in a different room, social distance, being trained in watching patients in clinical settings. So we had to adapt very quickly. What it meant to me is there's an opportunity here that we're not delivering. And now we're seeing huge interest. I'll give an example. So in the UK, Health Education England are responsible for postgraduate training of all healthcare professionals, including nurses and doctors. They have a budget of about £4 billion per year for training purposes. Last year, they paid, I think, about £5 million to buy headsets for the NHS. 300 HoloLens, 300 what's called HC Vive Pro. And now they are setting up immersive hubs across the UK to support training for healthcare professionals. That wasn't there 3 or 4 years ago, because people are seeing the value now. For surgical perspective, also VR, a company in the US, have shown that for surgical training, VR has over 200% more advantages in terms of learning experiences. The Mazer report showed that the learning in VR was 80% more than traditional online or e-learning platforms. So you see now the kind of the use case, the kind of the validation of those experiences. So I think now we move to a hybrid model. There'll be some face-to-face, which is absolutely fundamental and important to medicine, face-to-face clinical teaching. There's the online simulation, and now this virtual training, which adds more value. If we're looking at workforce that's diminishing, across the world we have a problem with workforce. There's a huge shortage of doctors and nurses. So how do you train people in a different way, quicker, more smarter? How do you give them the resilience, the training required on virtual platforms? So I think that also answers some of the questions around future workforce planning, smarter workforce, they're educated in much faster time. And those are the key advantages of being trained in that metaverse.
Et en une phrase, Dr Ahmed, qu'est-ce qui vous fascine, vous, à ce point-là, dans le métaverse?
I think it's the unknown. It's the journey into the future, right? Because I think many of us are here futurists because we come here together to think and plan. What I like about it is to really help people reimagine what health could look like, what education could look like in the future, and actually building for that future for ourselves and being in a position to, as a clinician at the front line, to create that journey or lead departments or organizations into understanding it better is just, I think, a great position to be in. And so I love the excitement around it, also around the anxieties that people might have around implementing change or translating into new clinical practices. But I think it's really exciting, and why wouldn't you want to be part of this?
C'est une excitation, en tout cas une passion qui est très communicative de votre côté. Merci.